Good morning, everyone. Welcome to Chautauqua Day. A little wet, but you braved the weather to come. We appreciate that. This is the Week 8 Science Group presentation. I'm Bob Spiritus. I coordinate this talk.
Oh, whoops.
I thought I did at least. No. Okay, I guess I'm still coordinating these talks. Today we have, we're welcoming Dr. Jean Wactawski-Wende. She has a PhD in experimental pathology with an emphasis on epidemiology from the State University of New York at Buffalo. Currently, she's the SUNY Distinguished Professor and Professor of Epidemiology, focusing her research on understanding factors that influence women's health. She is the principal investigator of the University at Buffalo Women's Health Initiative Center and leads the Northeastern Regional Centers, comprising 9 other institutions. She currently is the Dean of the School of Public Health and Health Professor, and her research interests include risk factors in prevention of cancer, osteoporosis, and periodontal disease in postmenopausal women. And she's focusing currently on the oral microbiome and health outcomes. This is her first time with a Chautauqua audience, so please welcome her warmly to Chautauqua.
Thank you so much. Can everyone hear me? Can you hear me fine? Okay, great. So just want to thank you for the invitation to talk about a study that's been ongoing here at the University of Buffalo and includes women from our region, including all 8 counties and then some from Western New York area, the Women's Health Initiative. We began this study many years ago, and it's still producing so much data. I'll try to summarize one of the major findings and let you know what we're doing at this point. So in 1992, actually, a request for proposals came out from the National Institutes of Health to look at the major causes of morbidity and mortality, disease and death in postmenopausal women. Came after a long discussion about a limited number of studies that had focused on women, had not focused on postmenopausal women. And what came together is a set of clinical trials and an observational study to look at some of the major questions at the time. One on whether hormone therapy was beneficial or risky. Could a dietary intervention that lowered fat reduce breast cancer and other cancers? And could calcium and vitamin D supplementation help in prevention? So these were all focused prevention trials. Now, the primary outcomes, depending on the trial, included heart disease, cancer, and osteoporosis, but there are many other outcomes that we've looked at. So the selection process involved writing applications in 1992 in Buffalo, along with 16 other centers. Were selected as what we call vanguards. We designed the different studies, implemented, started the process, and 2 years later, another 24 centers were added for a total of 40 centers that conducted research. And in these 40 centers, there were certain centers, for example, Alabama, Atlanta, Washington, D.C., Detroit, that were focused mainly on recruiting minority African-American women. Tucson, San Diego, San Antonio focused on Hispanic women. Tucson also recruited women who were Native American. Honolulu included women with background as Pacific Islanders. In total, over a period of about 4 years, almost 162,000 women were enrolled. We enrolled about 4,000 women from our Western New York Center at the University of Buffalo. And these numbers are very large. This was at the time the largest study ever done in one of the largest clinical trials. So we enrolled almost 28,000 into the hormone therapy trials. These were two separate trials, depending on whether you had a uterus, what medication you received, a calcium vitamin D trial, and a dietary intervention. And then this observational study was not a clinical trial where we're comparing intervention against a non-intervention. This was just, as it says, observational. We looked at all sorts of risk factors and looked at associations with health outcomes. So the planning at NIH began in 1990. We selected the centers in 93, and then, as I mentioned, 2 years later, the study recruited until 1998, and the main study was supposed to be closed out by 2005, about 12 years of study. Now, the main results that got the most attention was the hormone trial findings. As I said, there were two separate trials, one that looked at conjugated equine estrogen, which is Premarin, at a dose of a daily 0.625. It was the most common regimen at the time. Half the women of 10,000 women enrolled in that trial were put on the active drug, and half received a placebo. And those who had a uterus, another 16,000 women, also went on that same Premarin plus what is medroxyprogesterone acetate, or known as Provera, or a placebo, so placebo-controlled trial. In 2002, after about just over 5 years average time in the study, the Data Safety Monitoring Board is recommended that the estrogen plus progestin trial, the Premarin plus Provera, for women with a uterus be stopped. Now, as background, when we do these trials, we do them at what we call double blind. So it means the participants don't know whether on an active drug or placebo, and us as investigators do not know either. But there's a Data Safety Monitoring Board that looks at the data at different intervals to maintain safety. And they recommended that the trial be stopped, this trial, because they found an increase in breast cancer, a global index that looked at harm and risk that showed more harm than risk, and no cardiovascular protection, and perhaps an increased risk. So what did we find? So there was an increased risk in coronary heart disease, an increase in ischemic stroke, an increase in pulmonary emboli, and an increase in breast cancer. On the benefit side, hormone estrogen plus progestin was found to benefit hip and other fracture, and had fewer overall colorectal cancers, although they were at higher stages. No effect on mortality or endometrial cancer. So this report was put out in Journal of the American Medical Association, and it was really, I think, changed the world in terms of menopausal hormone therapy. Now, these seem like high risks, and these increases is over baseline risk. And to put this into perspective, if we had 10,000 women treated per year, we had 10,000 women of this age who were menopausal, who had a uterus, we would expect in background 30 of those women would develop coronary heart disease. In a similar 10,000 women on the estrogen plus progestin regimen, there were 37 per 10,000 women had heart disease. So 7 more coronary events, 8 more breast cancer events, another 8 additional stroke, and 8 additional pulmonary embolism. there were 6 fewer colorectal cancers and 5 fewer hip fractures. So for every 10,000 women who were treated with this in 1 year, there were actually 19 more negative events than if you had been on placebo or not taking that medication. So it seems like a small amount, but at the time, over 6 million women of this age were using this medication. And you take those 19 extra events times 6 million women, and you can see that in 1 year, there would be so many additional negative than positive effects of taking hormone therapy. So what happened was it got a lot of press. Women were trying to decide what to do. Many women stopped taking the hormone therapy, but the estrogen alone trial, I mentioned there were 2 trials that didn't include the progestin, kept going. And the Data Safety Monitoring Board had looked at the data for that trial and said the results were not the same. But 2 years later, the DSMB had a split decision on whether to stop the estrogen alone trial. And in the end, the director of the NIH made the decision this trial needed to stop a year ahead of time because there was an increase in stroke in the estrogen alone group. And just to give you an idea, nearly 40% increase in stroke in the women taking this, still a reduction in hip and other fractures. Breast cancer was actually lower, but didn't reach statistical significance. But if you looked at the risk benefit, there was certainly almost a balance of risk and benefit. But given we had aminobisphosphonates on the market that could help with hip fracture, it was unacceptable to have an increase in stroke when you had another medication to treat the osteoporosis. Putting it back to the per 10,000 women, there were 12 more strokes per 100 or per 10,000 women treated per year, 6 few hip fractures, and so this trial was also stopped. The one additional thing we were monitoring was a study that we included in the women who were 65 or over. We were doing assessments of their cognition and of dementia. And at the time, there was a thought that hormone therapy might be able to reduce the risk of dementia. And in fact, both the estrogen alone trial and the estrogen plus progestin trial showed an increase in risk. Here, the risk in the placebo group compared to treatment group. So in the estrogen alone, there was 49% increase in risk of dementia, probable dementia, in the women on the active hormone, and in the estrogen plus progestin, a doubling of risk. So increase in dementia as well. And FDA put on a black box warning on all estrogen products for use in postmenopausal women. Originally, the recommendation of the FDA was to use estrogens in hormone therapy for moderate to severe menopausal symptoms. They continued, but they should not have been given for the purpose of potentially protecting heart disease or dementia. And the recommendation was that these medications be given at the lowest effective dose for the shortest duration to meet the needs of women who were symptomatic. This gives you a graphic of what happened to the medication prescriptions in the United States when the results occurred. And so about half of the women who were on estrogen plus progestin ended up stopping their medication. So what was the impact? So we learned a lot from this study, but in terms of public health, I'm just going to give you one example of what happened. So at the time, everybody in our study and many women stopped very abruptly taking their hormone therapy. But in our trial, we continued to monitor the women. So up until the time of the trial stoppage in 2002, we were continuing to see an increase in breast cancer in our women on treatment. We stopped the medication, but we continued to follow, do mammograms. And this is what happened to breast cancer in the women on our trial. You can see that the stoppage of hormone resulted in a reduction back to baseline levels of what was breast cancer risk. And if you remember, I said we had an observational study. In that study, we were able to monitor in the women not on the trial and saw the same pattern that over time, and this is about when the trial stopped, we saw a reduction of breast cancer in our women. There were many dozens of other cohorts that looked at this phenomenon, and it's a thought that this reduction in breast cancer was actually real. So when about 10 years after this study happened, we had an economist actually look at the results of the trial and try to both financially and from a health impact, look at what the WHI trial did. The trial originally for the hormone therapy portion of it cost about $260 million to recruit the women, put them in the trial, follow them over time. But the economic return was $37 billion. So a return of $140 for every dollar invested in the trial. This is something that the NIH is very proud of in a trial that actually changed our use of medication, was actually causing more harm than good, and was a good investment. But I think more important was the health benefits in those 10 years following the stop of the trial, that 4.3 fewer women used hormone therapy in the United States during that time. And it's estimated in the following 10 years that we actually prevented 126,000 breast cancer cases that would have occurred in these women who took hormone therapy, 76,000 fewer cases of cardiovascular disease, and 80,000 fewer venous thrombolytic events, the pulmonary embolus that had occurred. So the top line is kind of get you through closeout. I can tell you the dietary trial showed a small reduction in breast cancer, but the reduction was statistically not significant. And the calcium D trial showed in the oldest women a potential reduction in hip fracture, women over 65. But the WHI continued first an extension study for 5 years after the main trial to look at the longer term effects of the interventions. And that has been extended now 3 more times. And currently we're in the newest extension to look at more around the health of the women in this important cohort. Now we had to reconsent women. 77% of the women reconsented to the follow-up study. Again, in 2010, we consented, where 87% agreed to continue. And we still get responses from these women over time that are somewhere between 85 and 90% response. We have lots of data that's being explored. So we collected baseline and across time measures on everything from smoking, physical activity, your dietary intake, medication intake, lots of assessments of mental and cognitive health. We do annual outcome assessments for heart disease, cancer, fracture, deaths, and then a lot of self-report on things like eye disease and Parkinson's disease and many other health outcomes. We do updates on risk factors. So we have assessed, for example, physical activity, frailty over time. We have blood samples available to look at mechanistic studies. And we have run biomarkers like genetic testing. So about 45,000 of our women, we've done a genome-wide association assessment. We have biomarkers like lipids, glucose, insulin, and the like. We've run vitamin D and many other biomarkers. We have GIS, the information. So we've done studies, for example, of air pollution in different parts of the United States related to health outcomes. And we have linked this data to Medicare claims data. So we are able to look at many, many other health outcomes in addition to those that we have been using. The study's been very productive. Over 2,200 published articles are out there. So if any of you use PubMed or you just want to Google WHI, you'll find lots of articles. We're producing about 120 articles a year. And we have another 2,000 approved papers in process that are being done in Buffalo. Many of our trainees use this data. So it's been a source not only for me and our investigators to publish, but it's something we've used to help train our students. In addition to the main WHI, we've had nearly 300 ancillary studies funded that help pay for example, the lipids, the metabolome, we're doing proteomics. So they are mainly NIH funded in our grants for those of you that are familiar with the R01 and other mechanisms. We currently have not stopped doing new science. So we have ongoing studies like the WHI memory studies where we continue to do assessments on a subgroup of women. We're in the middle of a physical activity intervention right now, the WISH study that randomized 50,000 of the women that were still participating into a physical activity trial assessment. We have a sleep study of over 5,000 of our women called the WHISPER study. 4,000 of our women are taking part in a cocoa flavanol multivitamin trial that'll be released this December. We have a study that is taking the many women who developed cancer and looking at their treatment, follow-up, survivorship, and factors associated with quality of life after cancer. We do objective measures of physical activity, and we're writing a follow-up study number 2 on that, where people wore monitors to accelerometers to assess their activity and that relation with health. We're doing a long life study where we brought in 2013, and we're bringing in this coming year, beginning in April, women to have home visits to look at practical measures of function, gain some additional blood samples. As I mentioned, we have a GWAS on 45,000 women that we continue to work with consortium to look at genetics and its relation to health outcomes. And in Buffalo, we're doing a couple interesting things. One, a study on assessing muscle mass and its relation with diabetes and cancer. And we have an ongoing study of periodontal disease in the oral microbiome in these same WHI women, looking at the relationship between the oral microbiome and other health outcomes. So as I said, we recently got an extension of this study to go to 2027. So we'll be following these women, what'll be nearly 35 years of follow-up. We still have 72,000 of that 160 that are alive and participating. And as I mentioned before, we continue to get a response rate of nearly 90%. These women are phenomenal. This picture was in the Buffalo News. This is Marion Ailes, who's one of our participants. She is 104 years old and still continues to fill out her questionnaires and participate. We have a remarkable group of women who continue to do this. As I said, we're doing large pragmatic trials in this group of women. So the science just continues. They're remarkable. Over COVID, we completed a set of questionnaires a year ago, and right now we're doing a follow-up study, and 50,000 of our women filled out questionnaires on their experience with COVID. Both did they get it, but also what were the impacts of the isolation and other parts of COVID, how many of our women got vaccinated, et cetera. So you can learn more by going to our website. It's just whi.org. And we encourage people to use the data. We have over 1,200 different people that have used the data. This, if you're ever at the University at Buffalo South Campus, this Buffalo is in Farber Hall, and it includes the faces of all the women that participated in the WHI. My personal email is just jww@buffalo.edu, and please feel free to reach out to me if you have any questions. I do want to acknowledge the generous support of the National Institutes of Health. The primary funding has been from the National Heart, Lung, and Blood Institute, but we also have funding from National Institute on Aging, the National Cancer Institute, the Dental Institute, and many more. These are just some of our students and faculty that have worked on WHI from our Buffalo region. As I said, it's been a great source of training for master's and PhD students who will go on to do this type of work in the future. So I just want to thank the participants, our faculty, staff, and students that made this a reality, and to our UB leadership for supporting us to do this study for many years. So I'll end there and can open up for questions.
Is this live? Okay, so if you're coming up to talk, please stand behind this tape so that you're not right in the microphone. And if you're coming from Zoom land, please do it by going into the chat box and saying, I have a question, or putting your question in the chat box. And we will try to alternate back and forth between those two. So Jim, would you like to ask the first question?
Thank you, Dr. Wactawski, for your talk, and congratulations to the investigators on this huge study. A reminder of why prevention studies have so much to help in terms of health outcomes. I wonder if you would expand on the finding from the estrogen alone study suggesting a reduction in breast cancer, and the estrogen progesterone study statistically showing a reduction in colon cancer. What that might have, what meaning that might have for future prevention studies.
Yeah. So in WHI, there were these two distinct trials. One for women without a uterus that just looked at the unopposed estrogen, and one with estrogen plus progestin that for women who had their uterus. And The findings on breast cancer were somewhat confusing, I would say. So there had been a lot of research, observational research, to suggest that estrogen plus progestin would increase breast cancer risk. We had some data from the Nurses' Health Study, another study from the University of Washington, suggesting an increase might be about 28%. And that's what we found almost exactly in the trial, that increase. But when we looked at the estrogen alone trial, although it was statistically insignificant, it was really borderline and quite distinct, that it looked like there might be an equal reduction in breast cancer and estrogen alone. We tried to look at biomarkers and other explanations of what actually happened there. I can say that we still are unsure whether it's the progestin that caused the increase, not the estrogen plus progestin. But the women in these two trials were slightly different. Those that were in the estrogen alone trial tended to be slightly higher BMIs. They were more likely to be Black and other races. They also went into menopause at earlier ages. So we haven't quite figured out what that means, but there continues to be interest in understanding that, because that really was one of the main negative effects of the trial. Also, the women who developed more breast cancer in the estrogen plus progestin trial tended to be more ER/PR positive breast cancers. And we saw those cancers stop, as I kind of showed you in the graphic, over time. So it's got to be something about the progestin that was added, but we haven't figured that out. For the estrogen plus progestin trial in colorectal cancer, there was a reduction in colorectal cancer, but Rowan Chablowski led a paper to look at that and found that although there were fewer colorectal cancers, they were actually more higher stage tumors. And so it's kind of a mixed bag, that there were fewer colorectal cancers, but if you got it, you had a poor prognosis. So, again, trying to understand the meaning of that, but I would say that we shouldn't interpret that result to be a positive. In fact, because they were higher stage tumors, the likelihood of dying from it was actually increased. We also showed in another paper an increase in lung cancer mortality in the HT women. There was not a pre-specified outcome. And so overall, the estrogen plus progestin group just was a much higher risk of having negative outcomes.
I was getting at the hypothesis that atrophic epithelium might be vulnerable to neoplastic transformation, and that there might be a special subset of women where atrophic hormone sensitive tissue would be particularly involved. But agree, and again, thank you for your nice presentation and the great outcome we benefit from. Thank you.
Thank you so much.
Thank you very much for your presentation. For those of us who are postmenopausal women and maybe not as scientifically versed in understanding that the studies go on and our learning goes on, nevertheless, what would you recommend in terms of life practices and health practices that someone in this age group might do based on what you've seen from the work that's been a part of this study, not only yours, but that of the many colleagues and others across the country who've participated? Thanks.
Sure. So I think, just just in general, good lifestyle practices like increasing physical activity, healthier diet, screening for early detection are all the mainstays that I think are recommended. In the case of menopausal health and use of hormone therapy, I think at the time there was a growing belief that hormone therapy was like a life elixir. There were lots of people being put on it. I remember my own mom at the time, she was in her 60s when this study was being conducted, and there were a lot of observational works that were suggesting hormone therapy could benefit heart disease. And she actually went on hormone therapy in her 60s without any menopausal symptoms or indications. Now, she ended up not feeling right on them, discontinued, but there was a lot of discussion about putting women on hormones at older ages for longer times to prevent these outcomes. WHI kind of made us stop and rethink. I think one of the things the FDA also did was not rely so much on observational data. You really needed trial data, and that became evident not just in hormones, but many other drugs. You had to show health outcomes, not interim. For example, hormone therapy was shown to reduce LDL, increase HDL, and have a favorable effect on the lipid profile, but at the same time was increasing risk of heart disease. So long story short, I think hormones can be used in very symptomatic women, but again, shorter dose, only long enough to achieve that symptom reduction, and then overall just healthier lifestyle. I think it comes back to pragmatic things we know, that diet, exercise, doing work to help us not be as frail as we age are all practical things that we should be thinking to do, not smoke, etc.
I have a question about phytoestrogens. And many vegan diets, vegetarian diets are high in soy and high in phytoestrogens. Is that protective or is that at risk?
So there's been, so I don't think there's many studies that support risk. How protective those studies are, it depends on the outcome you're looking at in the population. So very few people in the United States with the diets that we have achieve the type of levels that you might see in an Asian population that have a very high soy-based diet. There's been some suggestion of a benefit on bone health, but those studies don't support high risk or, in fact, high benefit for most of those studies. But there's not been large trials that can actually put enough soy in the diet. So I think more to come and understand.
Hi, thank you so much for joining us today. My question is, if you break the data down, did you see significant differences among minorities, among rural versus city dwellers, among regional differences, Northeast versus West Coast and that kind of thing?
Yeah. So within the trials, we did not look at rural urban within the trials that I'm aware of. We did look at race to see if there were significant, what we call interactions that might be more beneficial in one group than not. And we didn't see significant interactions by race, meaning the results generally were the same, regardless of race. We've done other work beyond the trials in the observational study to look at differences. Actually, one person has been working on looking at things like walkability, green space, and risk of falls and fractures. We've looked at, as I mentioned earlier, regions and relation of air pollution to heart disease that showed a significant effect. So there's lots of information out there, but not much in terms of racial differences. We have done some work in breast cancer that show that some of the risk factors, genetic risk factors, are somewhat different in Black and white women, but that was not part of the trials. No difference in the trials.
So this is a meta question. There's science benefits from repeated studies or studies done by different investigators. And I remember back during the time when the issue of hormones and cancer was hot, that the people at Oxford University pulled together data sets from all over the world and did combined or meta-analyses.
Mhm.
Is there any effort to combine the data you're collecting with any other groups? Or is anybody in the world doing some of the similar things? And does the WHI collaborate with any of these investigators outside of its own territory?
No. So, so we do a lot of collaboration. We're part of virtually every one of the National Cancer Institute Cancer Consortium. We have produced and shared data to look at cohorts that are looking at fracture. We've been part of meta-analyses that look at hormone therapy. The main problem is there aren't enough trials that are as large as WHI. So if we look at trial data, we really overwhelm any combined study. And because of the very concerning results of especially the E+P trial, there's been a reluctance to do another large randomized trial to look at say a different regimen or a different dose of hormone therapy. So we do participate, but often we become like the big gun in the room, and it's hard to look at anything else without WHI influencing. So up until this point, for example, we had a couple trials, the PEPI trial, to look at different regimens of hormone therapy, mostly for cancer and for heart disease outcomes. In the HERS trial, which was a trial in women with already heart disease to look at whether hormone therapy could reduce that. But those trials had a few thousand people in them. WHI, with both trials combined, is 28,000 women. So we kind of overwhelm the data in those instances. But because of our ongoing follow-up, we do have, for example, there's nearly 15,000 of our 160,000 women who develop breast cancer. But we have 1,000 liver cancers that have been accumulated. So we've added to a lot of science where there's smaller number of cancers, but we prospectively have data on risk. Did that answer your question?
Yeah, thank you. I know that the Oxford group was really doing some important stuff.
Yeah,
So,
and
and as well as the WHI, and the WHI will continue to add a lot to the science. But
Yeah.
the concern was, I guess, that the E+P was done only with oral administration, where
Yeah.
these drugs had to make a first pass through the liver, and then other kinds of routes of administration might be safer or have a lower dose that would eventually get to the, and the dose would get to the target organ.
correct. So we only tested this one regimen, one dose. Some of the data that looks at these meta-analyses use observational data, not trial data, and we could go into why that could be problematic. Even if you look at studies like Nurses Health Study, teasing backwards, trying to look whether there was a signal there or not. Data from the Million Women study in the UK, but it's observational, meaning women and their healthcare providers decide who gets the medication. And the problem is that it tends to be healthier women that are able to take these medications and are prescribed these medications. And so you have that kind of selection bias in observational studies that's a little difficult to overcome. So to look at other regimens is a little difficult without good trial data.
I have a question. Since you have this huge amassing of data, is it possible for other health and other scientists to come up with other hypotheses and run them through your data sets to look at other issues?
Yes. So as I noted, we have over 2,000 publications directly off the data and another 2,000 in the works. We have if you want to use the data, you propose to a committee, and then you're given the data to do your analysis and publish. So right now, over 4,000 scientific papers are out there. And as I said, we collect lots of other data on other health outcomes. We're connected to Medicare data sets. So for example, we have publications on risk factors for knee replacement and other factors associated with development of Parkinson's disease, macular degeneration, retinal eye disease. So the data is available, and we really do encourage people to use the data set. So it's out there. We talk about this all the time. How can we make it more available? There is a data set also. So most people come through WHI. It's a difficult data set because it's so massive and all the files connected. You're probably better off to work with somebody or a statistician that's worked with the data. But there is a public use data set that anybody can ask the NIH for, and it'll be shared. We also have stored biologic samples, mostly blood, but we do have some urine. So things like doing proteomics, looking at the metabolomics, and other things are certainly ongoing. And we have longitudinal samples from baseline 28 years ago. But as I said, we're planning to be in the field in April to try to get about 4,000 women in updated blood samples. So we've looked at telomeres, we've looked at all sorts of things in this data set. So if you're interested, give me a call and we can see what ideas you have to maybe explore the data we do have.
So, not seeing any other questions, we will thank you for your presentation. Hope we see you in Chautauqua. And,
Yes.
Thank you very much.
I hope you're having a nice day there. It's a little drizzly in Buffalo today. Hopefully you're enjoying some sunshine.
Well, not quite. But you brought us some sunshine with your presentation. Thank you very
Thanks.
much.
Thank you for having me.